to meet the demand of persons with dementia seeking a diagnosis of dementia within their own primary care physician's office. And it is a story of evolution that I'm going to present to you and the successes that we've found. I'm a specialist in internal medicine and geriatric medicine, and I've worked in the field both in the research of pharmaceutical drugs for Alzheimer's disease, but also in the academic world, partnering with McGill and with Trent University. We presented this research and were supported by this research, for this research by the Foundation for the Advancing of Family Medicine, which is part of the College of Family Physicians of Canada. Otherwise, I have no disclosures. The community that I come from is one that has about 1.6 million people, 11% of the population of Ontario. And seniors register very high in the census in the neighborhood of 20 to 28%, but 90% live in the community. It's fairly rural, and I've been working here for, 40 years. In the beginning, when dementia was first on the Richter scale, shall we say, efforts to initiate memory clinics were established at tertiary care centers, and I was involved in the first one in our area, but it was a very protracted assessment that lasted 3 different visits by several specialists, and it was obvious this was not going to translate to the community or the demand ahead. I have about between 2005 and 2019, I sent out a request to GPs in the area if they would allow me to have their office staff trained to do the cognitive assessments only. And I put in brackets nurse because I was surprised at how many of the individual doctors had no nursing staff, which was a crucial element in this analysis. At any rate, a decade later, a group from McGill wanted to study what people had done in primary care in Ontario, Quebec, and New Brunswick, 3 of the provinces of Canada. And I became the co-lead of the Ontario group. And 7 of the 8 sites were from this area where I had trained a nurse in a primary care location to just do the cognitive evaluation, nothing more. And the ROSA study became quite a landmark and pivotal moment in my life because it developed a evaluative procedure for looking at the charts of patients and looking for these 10 outcome parameters to see if they were noted in the charts of the individuals with dementia who had been referred, or with cognitive concerns who had been referred to the doctor. Sadly, this process of just having the cognitive evaluation only presented back to the physician failed to yield very good evidence of them acting upon or documenting many of these things. And this was the result in the 8 sites of people on those 10 parameters, what was in their chart. Now, I would caution that the physicians would say they discussed driving, they discussed home care, they discussed behaviors, but there was no evidence of documentation in the chart of these discussions in over, as you can see, most were under 50%. So this was a clarion call to me that we needed to do something differently. And when one of the sites that had previously had a nurse to just do the cognitive evaluation came forward and asked for me to train a new nurse to do the same thing, I challenged the center that was approaching us, the medical center, to do something differently. So in my community, which is pictured on the right, we have maybe 90 family physicians and many more nurse practitioners and many more nurses. But in terms of diagnosis at this time, there are 7 geriatric medicine specialists, 3 geriatric psychiatry specialists, and 2 neurologists, plus there are 2 specialist level teams at the Kawartha Center and at the GAIN geriatric team, which is at the hospital. But with the wait lists that were growing in each of the individual physicians' list, as well as the projections for dementia tripling in the next 20 years, we knew that the current system had to be changed if the data from the ROSA study wasn't enough. So we decided our philosophy had to be that every family physician needed to be involved in the diagnosis of dementia on their patients. They couldn't abdicate the responsibility to the specialist. And in many countries, and I would say the US included, diagnosis of dementia is not something that is viewed as being, even in the geriatric medicine specialist realm, often it's viewed as only in the neurology area, which is a recipe for disaster for the future. So we decided with the involvement of the Alzheimer's Society, the physicians in primary care, with myself and with the family health team, which is all the professionals who work with the GP, to develop a system with 2 trained professionals documenting in the patient file, which is an EMR in our language, and to create an internal structure at the pilot site, which is what I'm going to report on. We wanted to facilitate timely assessment and facilitate a return after assessment for conclusion with your GP. And we wanted to also, as a principle of this, involve the care partner in all activities when the client is involved. So the system was simple, a referral to the clinic inside the group at the medical center, which had about 20 to 25 family physicians, 8 nurse practitioners. And the appointment was booked centrally at one location where they looked after all of the details of coming and time, bringing meds, etc. And then the memory clinic assessment and the follow-up with the family physician or nurse practitioner. The study group consisted of patients seen during an evaluation period of August 2023 to February 2024, and the control group was generated from those seen by the single assessor prior to this introduction, and there was a little bit of delay because we had a lot of training and time before we went into the assessment phase. So we had approximately 50 people in both groups, and we also did satisfaction surveys from the patients and care partners, thinking that perhaps they wanted to see the specialist and didn't want to see a nurse in the family physician's office. And we looked at the quality of documentation of the historic group versus the study group as a primary endpoint. The 2 people that were involved in this were the Alzheimer's Society Client Support Coordinator, who was trained by me to do intake on the care partner, primarily for functional activities. But the family health team nursing staff, which consisted of RNs and RPNs, did cognitive testing, which is listed here, med review, depression screening, etc. The comprehensive intake took about 1 hour of direct time with the family and patient, and about the same amount of time for documentation. To service the 20 to 30 GPs and NPs that we had sending people, we needed a weekly or at least twice a month, sometimes weekly clinic. But the one thing that was very important was that the two individuals integrate their assessments into one report in the electronic medical record. And so what we've really said this, the results were as follows, and you can see that the beige folks were the study group. And when you look retrospectively in their files, you can see evidence at nearly 100% of the 10 parameters that are salient and important in a diagnosis of dementia. Comparing that to the group who had the single assessor. Now, I want to stress these rust-colored lines are the same doctors, the same family health team, the same group, but when they only received the cognitive evaluation, the documentation in those files, was very significantly less. They did have the cognitive assessment, but there were almost 50% without a functional evaluation, and you'll see 2% had evidence of behaviors and very little else about other things, possibly driving 30%. There was a notation. So this was a signal to me that the intake assessment done by the nurses in the evaluation were most important in the context of the primary care physician. We then looked at how quickly they got back to see their GP for the results of the study or the evaluation. And in the control group, where they were just receiving a retinue of cognitive tests, you can see the scatter goes up to 300 days before there was any follow-up necessarily written about in the chart. The bulk, however, were under 50 days, whereas in the study group, it was within the first month, and we aimed to have it within somewhere between 2 and 6 weeks, and I think we accomplished that in most cases. The satisfaction on the part of the partner and the care partner and the person with cognitive concerns was excellent. Over 90% felt that the communication and comprehensiveness of the service were good. They loved the fact that the care partner was involved in the care. They developed a sense of trust with the GP's office. The comprehensiveness was lauded by 96%. The continuity and the interpersonal communication was so high because for the first time, care partners felt that they got an opportunity to tell their story, which for me was a very important part of this process. Here is really one of the most important pieces. I'm trying to get rid of this black thing so you see it all. The analysis of where they got to, the family physicians, we provided them with a care pathway. This is a care pathway that has been developed in McGill for primary care, and it takes them through the sort of process of deciding whether the symptoms being seen and the cognitive evaluation being documented is consistent with a dementia or with MCI, and it gives also some guidance of what to do in each case, but it ensures that they go through a process of both proper investigation and looking for alternate etiologies. So you can see here in the study group, first of all, only 4 charts could we find no documentation. And I'm going to tell you that those 4 charts were related to the timing, that the physician hadn't yet seen some of the people that we, at the close off of this study. whereas 50% of the patients seen where they were given a cognitive evaluation, there was no documentation in the file about what the physician thought about the evaluation. So the data here is on the other 50% of the patients. You'll also see that there is in the MCI, the orange, and the dementia, considerably different numbers. So MCI was only 8% in the control group, 25% almost in the study group. And this, I think, reflects to the difficulty of diagnosing pre-dementia or MCI. You need to have the assessment of function to know what you're looking at because the cognitive evaluation doesn't tell it all. And the people, I think, were largely then assigned to the dementia category in the control group. Investigations for alternate etiology, 4% in the control, 25% almost in the other group, the study group, which I think shows a lot of detailed evaluation. And finally, under investigation. So I think this, more than anything, says that this is a good way to approach primary care diagnosis of dementia. And for pharmaceutical companies out there where they worry about finding individuals who are appropriate for clinical trials, it would appear to me that this methodology is supported strongly by having a good intake assessment done by the nursing staff. And in this case, the Alzheimer's Society was the other part of this. And I would, sorry, it's not moving now. There. So referrals to other diagnostic specialties, it improved the diagnostic referrals to more appropriate referrals rather than scatter referrals. And in fact, referrals went down in the group given more information. Referrals to the Alzheimer's Society in the study group were nearly 97% because the Alzheimer's Society was there and participating and made sure that they got to follow up with the family after, whereas only 4% previously. So our conclusions were that use of an adapted diagnostic dementia care pathway in family physician offices has proven to be very successful, and clinicians were able to evaluate cognitive concerns after intake in over 90% of cases appropriately, that specialist services benefit from more appropriate referrals and fewer scatter referrals, as I might call them. Primary care clinicians and memory teams benefit from ongoing dementia specialist involvement. So my presence intermittently helping the team was also a benefit to the physicians at the site. Standardized assessments and consistency of the intake process to involve both the care partner and the person with memory complaints is critical. But the narrative is almost more critical to my way of thinking because that's the language that the family physician needs to hear about how problematic the functional decline is. And I think the involvement of the care partner, not only in the assessment, but in the ongoing care, is critical for improved dementia care in all areas, but in family practice in particular, and is now a standard of dementia care in that primary care pilot site. Finally, integrating assessors from the community, such as we did with the Alzheimer's Society, allows you the benefit of staffing support, service integration, and coordination of care, and the families view it as very supportive when community services are there and available through primary care. So I thank our leadership table for guiding us, and I thank our funders and our partners, the only funder being the Foundation for Advancing Family Medicine. And if you wish to contact me, I'm present at these locations. And I thank my research associate, Sophia Alta, for her hard work in producing this. Thank you.
That's a great talk, Dr. Jennifer, thank you so much for your valuable presentation.